One, two, one, two.
Hmm. Oh, it's already there. Why is it that big?
If it's smaller, it won't. It can't send
So it'll
through.
just stay like that.
Unfortunately, sorry. We can make it full screen if you want.
I tried to.
Oh, oh, if, okay. Oh, I can.
thing and I engage people. Shades. Let's see. This is Westmore. Let's try this. Here you go. Thank you. Monopoly.
It was like they were supposed to do something.
Can everybody hear me? Good. I'm George Ehrbacher. Some of you know me. I did a family medicine residency out in Denver. Went to DO school in Kansas City. Did an internship in Cleveland before I did my family medicine residency. And then I was a family practitioner in a little bitty town in northwest Kansas for about 6 years. And after 100 hours a week for too many weeks, my wife said, "You ever going to see your kids awake?" And so that's how I ended up here. I came down here. I hated radiology, but Dean Fullingham, who's the chairman of our group, a guy got shot in the belly with a .45 slug, and it went into his pulmonary artery, and Dean snared it and pulled in the groin, and Rob Archer cut down on his groin and saved the guy a chest surgery, and I said, I'm going to do that, and that's how I got here. So my background, I did an interventional fellowship at the University of Cincinnati, and then they hired me here in '90, and I've been here ever since. So when I talk to you, I'm coming to you from a very much of a family medicine standpoint, okay? And what we're talking about today is people who have limb-threatening wounds on their extremities, okay? And that's what that's about. And this picture is really, you got to have a team. This is the team downstairs, and it's kind of old. I need to get a new picture of the new team because we have new faces, all right? But that's the team. And the other part of the team is we're a university setting, okay? And people who have life-threatening wounds in their feet have cardiology problems, they have nephrology problems, they have internal medicine problems, they have total body problems. And what I tell them is their foot's attached to a whole human being, and we need to pay attention to that whole human being. And I think this is too close, so I'm going to scoot it down, okay? So, and the first third of this talk is really what I want you to pay attention to. It's the history and physical, it's the pathophysiology, and what I'm going to share with you is straight from the American Heart Association. It's not something I made up. And why is that important? Because the American Heart is a multidisciplinary organization. It's got vascular surgery, it's got cardiology, it's got nephrology, it's got interventional radiology, it's got vascular biologists, it's got vascular internists, it's got a lot of folks. And so they're kind of consensus documents. But because of that, there is actually some evidence, okay? And in this world, there's not a lot of evidence, all right? So if you've got an acute or chronic wound, you're not going to get better unless you have artery supply in, venous return back, and then all these things that should happen down in the wound center. So when you see a wound and you palpate that foot and it's got bounding pulses, you got good enough arterial supply. We'll talk about that. Remember, I said that person with the wound, they're a total person. So smoking, huge problem. Hemoglobin A1C, 13, huge problem. Non-compliance, huge problem. Poor nutrition can not only be overly skinny, but the BMI of 50. Immunosuppression, prednisone, Imuran, all those things that people are on for their Crohn's disease, rheumatoid arthritis, and all that stuff. Now, when I was in family practice, I used to use peroxide and betadine and all kinds of stuff. Now those things are considered toxic cleansing solutions, okay? And in fact, the British Medical Journal just said, how should we deal with wounds? Soap and water and Vaseline. Estrogen deficiency, especially in the female world, social support that's poor, matrix failure. All right, so let's keep going here. Whoops, I went too fast. I'm sorry. Venous disease. I work in the venous world too because you've got to. 80% of all wounds have a venous component, and that's super important. We don't think about that, okay? Wounds are often about the medial or lateral malleolus, and what do? If they got bounding pulses that are ABIs are good, we do a venous refill exam, an erect duplex ultrasound by a vein physician, which I do every morning over at the OSU Comm Clinic at 2345 Southwest Boulevard, and we're looking for reflux, okay? Where is the blood running backwards in the system? And based upon that, we treat them. Everybody's going to be put in some form of compression, and there's a myriad of ways to do compression. If they have a great saphenous vein or lesser saphenous vein that has bad reflux, we offer ablations, and in the old days they used to strip them, and there's just a lot of things we can do. We also offer duplex guided foam sclerotherapy for people who need that, and I'm going to quit talking about that. What is peripheral arterial disease? It's extremity atherosclerosis causing diminished flow to the limb. If you're a cardiologist, what's angina? Okay, the heart calls for more blood because it's exerting, and you got flow-limiting lesions, and you get pain. Same exact thing, okay? And what we want to talk about here is critical ischemia, rest pain, non-healing wounds, gangrene. So I divide this into rest pain and tissue loss, all right? And that's what we're going to focus on. Intermittent claudication is really common, and most of them should never see us, okay? Diabetes increases the risk 5 times, increases the amputation rate to 21%. Cigarette smoking, big deal, all right? Intermittent claudication worsens in 31% who continue, 8% who stop. And this is something I share with the folks who amputations are required in 11% who continue to smoke, 0% who stop. And this is a big number. 5-year mortality in those who continue to smoke is up to 90%. It's usually MI and stroke. The risk of sudden death is 8 times higher. So we have the Oklahoma Stop Smoking Helpline. I have all those little cards downstairs, and every single patient that we see who smokes, which is most of them, that we hook them up with that and you dictate that, all right? That's part of what you do every single time. And if these risk factors look like the same risk factors for heart disease, it's because they are, okay? And you got to approach them. What's the fate of claudicators? 75% of the time, no big deal. 25% will deteriorate, have a progression is gradual. And we have a really big weapon nowadays that we didn't used to have for people who are claudicators, and that's called statins. The cardiologists have shown that in the heart, if you use moderate to high dose statins, Lipitor 60 to 80, Crestor 20 to 40, those kind of things, you can see up to 50% plaque regression in a year's time. That's a big deal. So a walking program, stop smoking, moderate to high dose statins, antiplatelet agents, and that's how we treat that. Super important. Peripheral arterial disease occurs late in the natural history of atherosclerosis. By the time you have PAD, you've got bad coronary disease, and you probably have bad cerebrovascular disease. So what's that mean? You got wounds on your foot, you can't palpate pulses, you better be listening for carotid bruits. You better be asking about chest pain. You better be asking about all this stuff because it's total body atherosclerosis. The overall 5-year mortality is 30 to 50% with what I said, coronary events and stroke, the major cause of death. 10-year survival is 25%. So these people are on the downhill side of the curve. Super important again. How do we evaluate these people? History and physical, by far and away the most important thing we do. Ankle brachial index. Now I try not to do this, and I know a bunch of my radiology colleagues are in here, And I hear all this monophasic, biphasic, but what's that mean to me? It means absolutely nothing, okay, because I'll tell you why in a minute, okay? And transcutaneous O2s. And when we get to the American heart, it's going to give us numbers that help us with ABIs and TCOMs. There are no numbers here that are helpful, okay, and I'll talk about that in a minute. So on ultrasound, when we're looking at the phasicity of flow, it's dependent upon what we call peripheral vascular resistance, okay? So a monophasic waveform, which everybody interprets as being I got stenosis, can occur if you have stenosis or occlusions, but it can also occur if you have distal infection, which induces a distal AV shunt and decreased resistance. It can happen with cancer. It can happen with anything that causes neovascularity. So what does it really tell you? Not much, so I try not to do them. So, and I see a lot of people wanting to do a lot of these. And when you get out in the community, I get a phone call. We've done a CTA and they've got a SFA occlusion. You want to see the patient? No, I don't want to see him, not unless they got a problem, okay? If they got a wound, okay. But what does that tell me? Nothing, okay? The history and physical tells me something. The clinical exam tells me something. And the ABIs and the TCOMs tell me something. Not all these $1,200, $3,000, $4,000 tests. Now, remember I said I'm not sharing with you something I dreamed up. This is straight from the American Heart. And they had a revision of this in 2013. So it's been updated. And you can go online, pull these things up, and it tells you exactly what to do, okay? And in fact, this is exactly what to do. Diagnosis and treatment of critical limb ischemia. And one of the things I want you to pay attention to is, number one, history. Ischemic rest pain, gangrene, all this kind of good stuff. Next box, history and physical. Next box, assess risk factors. Next box, ABIs, TBIs. Next box, ABI less than 0.4, pulse volume recordings flat, absent pedal flow. Now we're starting to get excited. Severe lower extremity PAD documented. Systemic antibiotics of skin ulceration and limb infection are present. The VA did a study about 10 years ago, took people with foot wounds, put them on antibiotics for 6 weeks, most of them healed. Interesting, okay? Now, after you've done all that, then you get to talk to the vascular surgeons and nussons that mess around, okay? Then we start asking questions, do they need to be revascularized, all right? And whether they're a candidate. But I think the important thing is the majority of this slide is not prompt vascular specialist evaluation, okay? Only after clinical exam. Now the TASC, which is the Transatlantic Society, is the equivalent of the AHA in Europe, and they say the same thing. So we actually have some agreement. What's claudication? Claudication is usually caused by focal stenoses, exertional cramping or pain in leg muscles with exertion. Key, exertion, 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 all right? It occurs only with a specific level of exercise and resolves after 2 to 3 minutes of rest. What can look just like that? Central canal stenosis, musculoskeletal problems, venous disease, and these almost, that one and that one almost get ignored. And if you put that one and that one along with arteries, you're looking at 90% of why people have pain when they exert. You've got to ask those questions. Robert and I just got finished seeing a guy downstairs. A lot of people get sent to us for claudication, and he says, you know, Doc, if I go to Walmart and lean over the cart, I can go as far as I want. But if I stand up and walk like this, I can go with 20 feet. That's a marker for central canal stenosis, okay? Good palpable pulses, lean over the cart in Walmart, they got spinal disease, okay? History, rest pain, usually caused to multi-level occlusions, ischemic neuritis. So if you ever gone to church and you fell asleep with your legs crossed and you stand up and you get all that burning pain when you first stand up and it takes a while to go away, that's ischemic neuritis. These people have it in spades. There's not enough narcotic to deal with that. So on the medicine unit, or you guys, when you're working in the ICU and these people come in with critical rest pain, do not spare the narcotics, okay? There's just, you got to keep breathing, okay? But I see 0.5 milligram of Dilaudid. Well, that's nothing. I mean, that's a Tylenol, okay? So when these people have bad pain, you have to help them. Some of the things that can help you with the pain, if their kidneys can tolerate it, throw in a non-steroidal, a little Toradol. Throw in a little Lyrica or something like that. And what we do downstairs a lot is we put Emla cream where it hurts. That really helps, okay? And it cuts down on the use of narcotics, all right? But they have pain, give them some medicine, all right, or they're not going to lay still, all right? Non-healing ulcers, gangrene, worsens by elevation, relieved by dependency. And what do we look for on clinical exam? Hair loss, pretibial hair loss. Now in Oklahoma, we wear cowboy boots, and that'll also cause hair loss. So just because you got a hair boot doesn't mean you got artery disease, all right? Venous disease can cause the same thing. Toenail, you see those big, ugly, onchomycotic nails, muscle atrophy, rubor when lowered, pallor when elevated, and tissue loss. Document the tissue loss. I have a Wagner 2 wound. It's 3 to 5 centimeters. It's located XYZ. It's been there for 3 months. You and I, we get a wound on our foot, we're going to be healed in a week or so, okay? And if you aren't, ask questions. How come? All right, really important. So what are you looking for? Decreased pulses, cool leg and foot, decreased sense, decreased motor. Now, when you start getting into the decreased sense and decreased motor range, it's almost time to call our buddies for an amputation. And we don't want to do that, but if you come in with a cold cadaveric leg, don't call me, call the people that need an amputation, okay? If it's a cold cadaveric leg with loss of motor activity, that's a dead leg. If we open a dead leg, then we liberate all those metabolic products, they get in the bloodstream, and they die in front of you, okay, which is not good, okay? So we won't do those, all right? Ankle brachial index, super important. The single most important thing we do, it's like a blood pressure. Highest Doppler reading foot, highest Doppler reading arm. You can do it. When I was in family practice, we used to get $60 for doing these. I did them by the millions. Not really, but I did them a lot, okay? Taken after the patient's been at rest, quiet and supine, inflate the cuff 20 millimeters above the highest arm pressure, slow cuff deflation. Now, just like blood pressure, what does 1 ABI mean? Not a whole lot. How about 4 or 5? Yeah, that's significant. BP, same thing, okay? Take several readings on several occasions before deciding abnormal. This says 10% variation. I believe it's 15% variation. If you look at the AHA, a significant change in ABI is 0.15. That's a 15% change, okay, because of the variability. Now, do we diagnose peripheral arterial disease with an ABI? No, we don't. We diagnose PAD with a history and physical, and then if the ABI agrees with it, then we say, yeah, you got it, okay? So we think a person comes in with a black toe, and, you know, their toe pressures are terrible, and their ABI is 0.3, yeah, that fits, okay? It's time to get things going, all right? So that's where it helps. You don't do a test and make the diagnosis. You do a clinical exam. These are magic numbers. I want you to put these in your brain book, because this is what we pretty much live with, okay? So evaluation of a diabetic foot for salvage, the toe systolic pressure needs to be greater than 30. The transcutaneous O2 needs to be greater than 20. Now, the people in the wound center, they like those TCOMs up in the 30 range plus, and I have no beef with that. The other thing is, even though we have magic numbers, if Blackwell or Duckett call me up and they've been treating something for 3 months, it's kind of borderline, we're losing, we're going to go fix them, okay? The clinical always trumps the numbers, always trumps the numbers, okay? Super important. Critical factors imaging. When we take pictures, you have to look from the aorta to the end distribution. And if that's your legs, that means from the aorta to the toes. Can you look at a picture and decide what can be done? No. You cannot make revascularization decisions based on imaging. You need what we used to call guide wire traversal test, and that meant you go poke it with a guide wire, and if you can't get across it, you can't fix it, and you got to send it to surgery, okay? Now, we have all kinds of things that help us get across those, little jackhammers and stuff, CTO devices, and we'll talk about that a little bit. What are ways to look at the vascularity? Catheter directed. Now, one thing has changed, okay, and I've had a really hard time helping the world of medicine understand this. In the old days, X-ray dye was a salt of iodine, okay, like sodium iodide. What's changed, okay? Sodium iodide was like 2,200 milliosmoles. You dump it in the bloodstream, mast cells are liberated, the endothelium was hurt. I remember when I first started doing angiograms, we'd give them 10 of morphine IM, put 10 of lidocaine down each artery, dump in the dye, and they'd scream and holler in pain. It was horrific. What's changed? Now they've invented X-ray dyes that are isoosmolar. They're the same osmolality as saline or your blood, okay? What's changed about that? Well, there's one called Visipake that did a study up at the University of Kansas about 10 years ago, and they took people with creatinines of 2 to 10. They gave them 100 mLs of Visipake for CT scans, and only 2% did the renal function bump, okay? And what does that really tell you? All this freaking out that we do because of iodinated contrast material, we shouldn't be doing anymore, okay? And with judicious use of contrast, we shouldn't be having those concerns. The same thing goes for metformin. We all freak out about metformin. If you look at the metformin data, there is no data to support taking people off of Visipake or any of those kind of things whenever you do contrast studies. In the original studies, those people were already in lactic acidosis before they got their contrast materials and were on metformin. But it's embedded, and we still do it, okay? So we do a lot of things that aren't supported by data anymore. Plus, our machines downstairs can use CO2 if people are really crazy. I use color Doppler after I've done a history and physical. I know what's going on, and I'm wondering, is this an SFA occlusion, a popliteal occlusion? I don't do it very often, all right? MRA and CTA are not equivalent to a catheter angiogram, and they're not equivalent to color Doppler. What does a catheter angiogram and color Doppler also tell me about? It tells me about physiology of flow, velocity of flow, slow flow, fast flow, stuff like that. An MRA or a CTA is a snapshot in time. They give you the dye, the scan's done in 3 seconds, and if the dye didn't get to where it was supposed to get to, you're just not going to see it, okay? So it's not a real picture, okay? And I can tell you stories about that. What's the role of MRA in the setting of limb salvage? In the MRA contrast material can get into some dorsalis pedis and posterior tibial pulses and vessels, when we can't see it with regular contrast. How does that change things? I've seen Larry Dooley do a FEM to faraway bypass and save a limb. So yes, it can make a difference, okay? Summary of MR and MRA. MR by far and away is the best tool we have for looking at infection anywhere. And if the vascularity needs to be studied to a higher extent, MRA is a good tool. Interventional radiology are those of us that use imaging tools to fix things. So let's talk a little bit about conventional treatment. Now remember, I'm going to be talking about people with tissue loss, okay? We talked about lifestyle changes and medications. That's kind of in the claudicant range. These are some of the tools that are used, okay? All right, you can kind of go there. We're trying to really avoid that one whenever possible. If you look at the long-term mortality and morbidity associated with amputation, it's off the wall. It may be cheap right now, but in the next 5 years, it's not, okay? So that shows somebody getting a saphenous vein harvested so they can get something done. Now I'm going to talk about a lot of what we see, diabetic arteriopathy, and I'm going to go through this pretty quickly, but we see lots and lots of diabetes. Oklahoma is rich in smokers, rich in diabetics, and rich in obese patients, okay? So we have a lot of richness. In the diabetic population, the risk of developing lower limb critical ischemia is 5 times greater. Now, if you really want to make it bad, throw some ESRD on top of that, okay? Now we've got the worst of the worst. Maybe the worst of the worst would be a smoker, end-stage renal disease patient, diabetic with a hemoglobin A1C of 14, okay? That's kind of the best of the best in terms of having really bad disease, okay? What's the characteristics of a diabetic arteriopathy? Increased amounts of connective tissue, increased amounts of calcium. Those of us that work down there, you know, we'll fluoro and we see all this calcium in those vessels. And I want to bring that up because in the old days, we used to put nitro on their foot. We used to use Trental and all kinds of stuff like this because we thought we were going to vasodilate them. That is nonsense. You're not going to vasodilate a hard pipe that's made out of calcium, okay? So Plital is the only thing that you guys can prescribe that may help with intermittent claudication. Anyhow, leads to a loss of elasticity of the arterial wall. That shows some of that stuff, and this shows that you can open those. Now, when I trained, we were taught never touch any of the vessels below the knee because you're going to cause an amputation. Now we know if you don't get them open, you will cause an amputation, all right? So this is what we spend our life doing. What are the indications for revascularization? Risk of amputation? Maybe we can turn them into a transmed instead of a BK, all right? That's important. The more limb you have downstream, the better your chance of rehabbing. So that's a really important part. Critical limb ischemia, pain at rest, ulceration, symptomatic claudication. When do we hit claudicants? What we do, and this is what the American Heart says as well, is if you don't have lifestyle limiting claudication, you're going into medical management. We talked about what that is. If you fail medical management, you're still having activity of daily living, limiting claudication, then we'll work on you. And why is that important? If you're a limb salvage patient, if you're about to get an amputation, and I screw up and you get an amputation, you've lost nothing, okay? So the risk-benefit ratio is way towards benefit. And whether it's me or a vascular surgeon or whoever it is, okay, the risk-benefit ratio is all benefit. Not true in a claudicant. If you turn somebody who's just having some trouble walking into an amputation, you've really messed with the risk-benefit ratio there, okay? And remember that the majority of claudicants can be taken care of with medical management, all right? And that's really important, okay? So how do we do this, okay? Itty bitty little wires, small as a lady's hair, really long balloons, maximize medical therapy. Nobody leaves without being on moderate high dose statins, antiplatelet agents. Now, is Michael Carney here? Michael likes to talk about platelet resistance to antiplatelet agents. Some people think up to 25 to 30% of the people that take Plavix are resistant. I read a recent article that said blacks and Asians are particularly high. However, if you toss in an 81 milligram aspirin, you don't have to worry about that. So it's a real cheap approach. They actually make little point-of-care instruments that will measure platelet reactivity, but they're expensive and the hospital won't buy them. So a baby aspirin is a cheap approach to the same thing to make sure that your antiplatelet effect is there. And then we use ACEs and ARBs. So when we're fixing these people, what do? What we're trying to do is improve the perfusion. We need more blood flow, okay? So whatever is blocked, we fix it, and that's what that means. Recanalize as many arteries as possible. It kind of shows that. And that shows some wounds that got better, okay? Optimal revascularization aims to obtain direct flow to the foot, preferably through the pedal, anterior tibial, plantar, posterior tibial. Now in me, if you go whack out my anterior tibial artery, my posterior tibial artery, because I have an intact plantar arch in my foot, no big deal. Not true in a diabetic. People have been diabetic for a long time. They lose their plantar arch. So if they have something in the midfoot to the forefoot, they really need to have that anterior tibial open. If they've got something in the hindfoot or the plantar part of the foot, they really need that posterior tibial open, okay? So diabetics are different, and that's going to make a difference here in just a minute. So that just goes to show you can get stuff open. We have little bitty balloons that go all the way into the foot. In the presence of an ischemic foot ulcer, basically fix everything. I'm going to go through this pretty quickly. And these were all pictures that in the old days nobody would have touched, but now it's part of limb salvage we do. And this is something we didn't used to be able to do. This is a perineal that looks pretty crappy, and it shows off. This is called a medial malleolar branch, and it collateralizes the posterior tibial distribution. Now we got itty-bitty balloons we can put in there, stretch those things out, and maybe keep you from getting amputation. So pretty useful. Remember I said the hard part of all this is how do you get across the blockage, okay? We used to poke on it with a guide wire, all right? It's sometimes really hard, okay? Historical success rate, this says less than 80%, I'd say less than 60%, okay? And it was just really hard. It was the most common reason to send people to surgery, and I think I send a lot of people for FemPops because I can't get across them, okay? Now we've got all kinds of tools that help us get across, okay? And these are just some of the names of them, and these are some of the ways to do it. In fact, just before we came up here, our people were playing with the Pioneer. Did that get brought up, the Pioneer? Pass it around, okay? Because we're going to show pictures of it. These are all tools that help us get across blockages. This is a little 018 burr, and just think of a little grinder, and you put it in there, and you try to grind through the thing. This is a little auger. Okay, it's a deal to auger through it. It's called Avinger Wildcat, and we don't have that anymore. We do have this thing downstairs. It's called a crosser. We're going to talk about that in a minute. This looks like a little blunt dissector, because it is. This is the Pioneer. This is what gets passed around the room here. And if you get outside the vessel and you don't know how to get back in, this has got a little ultrasound probe here, and you turn that thing on, and it says, rotate this thing towards where the blood flow is, and then this needle projects, and when the needle projects, you put out a wire, you got it fixed. The Outback is the blind version of a Pioneer, and we'll talk about that a little bit. This shows how the Pioneer works. So you get outside the vessel, subintimal or wherever else, and you don't know where you're at. This turns on the IVUS, and you say, I found the vessel. You turn this thing, you rotate it. When you rotate it just right, you can project that needle. You project the needle, get a wire across it, and once we get a wire across a blood vessel, it's fixed, okay? That's the hardest part. Another way to get across blockages is using lasers. This is called Turbo Elite, okay? This is the crosser. This is the old way of doing things, is buckling a wire and hoping it goes across someplace, okay? And our main problem is where are we? Are we in the vessel? Are we outside the vessel? Are we between the vessel walls dissecting? We don't have a way to figure that out. This is the crosser, okay? And basically what it is, I'm hoping, okay, is this is a little ultrasound gizmo, okay? This is an ultrasound transducer, and it pounds on a little nitinol wire. This oscillates at 20,000 hertz while we inject cold saline through it. If I turn this thing on and put it on my hand and push on it, it doesn't do anything. If I would put it on a sheetrock wall or a piece of calcium, it'll bore right through it, okay? So it's a pretty cool tool, shows a jackhammer. Really what it does is it cavitates. Because it oscillates so fast, it creates microbubbles, and those microbubbles of saline will actually eat through the proximal and distal cap, and that's how that works. Now, what's the root problem with all these? They're blind, they're dumb, they don't know where they're at, okay? Are you in the vessel or are you not? And right now, we don't have a tool that tells us we're infraluminal. There's been a bunch of people working on them. The bottom line is, once you get across the blockage, you can fix it. So we're all excited about using tools that help us get across blockages, all right? Now, the crosser is unique because it actually eats up some clot. Somehow the FDA has classified it as an atherectomy device, and that makes a big difference because all these things are expensive, and if you can't get the thing paid for, that's a bad deal. We can get the crosser paid for because it's considered an atherectomy device, and that's pretty important, all right? So I'll keep going here. Now, what happens is if we do everything we know how to do to get across the blood vessel from what we call antegrade, and classically what we do is say if you have an ulcer on your left leg, we'll access the right, turn our tools and go down this ways. That's called antegrade access. And I'd say 70-80% of the time we're successful. What if we're not? What if there are no surgical bypass options? That happens a lot. And so I got sent up to Wyoming, Michigan to learn how to do this, and we've been doing it. And basically what it is you access a dorsalis pedis or a posterior tibial or a perineal from below and cross that occlusion from below. Now, cardiology has been doing radial artery access for a long time. Not a whole lot different than that, except we're doing it to get across occlusion. So it bumps up the number of people that we're able to fix as compared to not. That shows a non-healing wound at presentation. And this is a transverse ultrasound image to show the posterior tibial artery. Posterior tibial artery, anterior tibial artery, perineal artery have paired veins next to them. And with ultrasound, you access that little thing, and you put in a little tiny needle, you put in a little tiny sheath, and you push up a wire or whatever it is from below. You get across the blockages, and it lets you fix them, okay? So that's markedly improved our ability in patients especially that we weren't able to fix any other way. They had no surgical options. They had no options from us. And this shows doing what's called an orbital atherectomy from below. It's one of the tools we use to open stuff up. So, and the wound's healed. Now, once you get across, what are the ways to try to fix it? Well, dilatation, which you've been doing it forever. Stents, there's a bazillion of them. Atherectomy, which I like to do because I figure if something's plugged up, why not remove the stuff that's plugging it up? And we're going to talk about several of those. Polar cath, we don't do so much anymore. The idea behind that is if you cool the inside of the vessel, you won't get atherosclerosis with a vengeance. It didn't work. This slide, I think, is a super important slide because the SFA is the most difficult artery in the body. And why is it? Because of all these forces, okay? So there's compressive forces, torsional forces, more compressive, twisting. So whenever you cause resistance to blood flow, like at a bifurcation or here in the SFA going through all these torsions and stuff like that because you're moving, you get high incidence of atherosclerosis, okay? So that's why it's a very difficult process to deal with, and I'm going to kind of go through this. This is basically a little refrigerator built in a balloon, and I'll go through it pretty fast. We don't do it so much anymore. Stents, many, okay? Lots and lots of different kind of stents out there, and certain specialists, they love to put in stents. I hate to put in stents, okay, and I'm going to tell you why, okay? Most stents are metal, all right? And if you take out my SFA and you hold it up like this, it's going to be like a piece of spaghetti. You just took out a pot of hot water, okay? It's all nice and floppy because that's the way God made arteries. If you put a stent in there, is it going to be all nice and floppy? No, it's not, okay? And we call that modulus of flux, okay? So as I bend whatever happened to be that artery, let's make it my SFA, the motion that used to be in that stented segment, where does it go? It goes to the end of the stent. And the ends of the stent dig in repeatedly, repeatedly, repeatedly. And when cardiologists see this in the heart on a heart stent, they call it candy wrapper stenosis because the body scars down around the ends of that. Now, most stents are bare metal. Most of them have open cell structure, which means they're 80% nothing. What's to keep atherosclerosis from growing through the side walls of the stent? Nothing, okay? So when you put in a stent, it's going to be down in about 18 months, okay? So I don't think that's a grand idea. Now, I do a fair number of these. This is basically an endovascular fem-pop. It's Gore-Tex with nitinol on the outside. The good news is it works really good. The bad news is they're very expensive. The 25-centimeter one is what, Mike? Is he up here? Like $6,000. Okay. $6,200. Okay. But a real fempop is about 26,000, all right? And our people are going to go home with a Band-Aid in their groin. Atherectomy, this is what we prefer to do. This is an atherectomy tool. This is basically a laser mounted on a catheter, and you kind of go buzz that stuff out with the laser. There's another device. Some other specialists here in town use this thing. It's called the Jetstream. The idea is you got a little blender gizmo down here, and you suck here. The literature I read says it has a 30% embolization rate, which makes sense to me because the blood flow is going this direction, and the blender's on this direction. I don't think you can make enough suction there to keep the crap that you generated here from going downstream, okay? So that's just my deal, and I don't do it. So we do this. This is called directional atherectomy. It's called the Silverhawk. Basically, this is a little cutter wheel. Now, the new ones are designed to cut calcium. They're designed to cut about everything. And you put this thing in a blood vessel. When you activate it, that little cutter wheel comes on. This is a little knee joint, like a little knuckle. It opposes it against the wall of the blood vessel. And as you push it forward, the little cutter wheel shaves off some of the plaque. If you've ever planed a door, you're doing the same thing, okay? Now, the plaque actually gets stuffed in this nose cone, so it collects the stuff. And when we do it over something called an embolic protection device, which looks like a little windsock that's a little basket that collects stuff that goes south. Because no matter what you do in a blood vessel, just putting a catheter, just putting a wire in there, you're sending stuff distally, okay? So the beauty of this is you can do it over an embolic protection device. So anyhow, and then after that, you do a little angioplasty. So this shows some one-year patency rates, angioplasty versus stent. You can see that's not much different. And this kind of goes over in a way how angioplasty works. So what does angioplasty do? It just stretches the blood vessel, okay? In the old days, we used to do something called, we'd inflate the balloon enough to cause it to have pain. What were we doing? We were dissecting the vessel, and we thought that maybe if you dissected it, it would heal in the open position. The blood vessel has something called intima and then the media. If you expose the media, you get atherosclerosis with a vengeance. So our idea with angioplasty has changed. We do one-to-one inflations. We don't want to cause pain. And guess what? We don't get as much atherosclerosis as we used to. What's a stent do? Does the same dang thing that a balloon does, but it just holds it open. And remember my story about the modulus of flux. So it seems to me an osteopathic concept is the open artery works better. I think somebody said that once, okay, like Andrew Taylor Still. So that's our approach here with plaque excision. Get rid of the stuff that's in the blood vessel, all right? Now, the IVUS guy was just downstairs, intravascular ultrasound, and that's really helped us, okay? So this shows a kind of plugged up vessel, and this is after you shaved out some of the stuff, okay? That shows a bad wound, get across the blockage, and fix it, and the wound's healed. Now, this is another tool for doing atherectomy. We used to do this quite a bit, okay? This is called orbital atherectomy. If you put some sandpaper on a fishing weight and put it on a metal cable and you spun it, it would spin eccentrically, okay? So the faster you spun it, the bigger the orbit, the more it would sand out. And what this is a sanding. This is a piece of carbon, and you can see when you spin it fast, it makes a bigger orbit, all right? And if you put that in my artery and turned it on, it wouldn't do anything because I don't have calcium in my artery, all right? Now, I did this a lot for a long time, and one of the things people would ask me is, well, what happens to the stuff you knock off, okay? What happens to that calcium? And the company actually did study on porcine, on pigs, and they looked at that, all right? And what they showed is that a red blood cell has a diameter of around 8 or 10 microns. The particles that went south were about 2 to 3 microns, so a fraction of the size of blood cells, and it's just not a problem. Okay, that's what they told us. Okay, I did a couple of patients who had been diabetic for 30 or 40 years, and when I was done, they had purple feet. Okay, what happened? All right, I sent off microemboli. Those people do not have a healthy vascular bed. They don't have healthy capillary bed, so I micro-showered their feet. Okay. So I try not to do this unless I'm desperate, okay, because I'm worried about that. When you take a healthy person, yeah, you can do this a lot, okay, but who are we working on? The ESRD, long-term diabetic, smoker, okay? They have the worst of the worst. Their vascular beds are destroyed, okay? And so you can do it for all over the place. So non-operative alternatives and adjuncts, we talked about those things, all different kinds of stents. Tools are changing almost every day. At this time, we use a common combination of devices. One of the ladies who sells us the TurboHawk device, I didn't use her tool that day, and I walked out of the room. I thought she'd be upset with me. And I totally respect her because she said, you got to have a lot of tools on your shelf, and no one tool is going to do it. We got $1.5 million worth of tools on the shelf. We never know what the heck we're going to do. We have to get in, and we have to customize it for each individual person, and there is no miracle single tool that always is going to work, okay? So what happens when vascular surgery and us and everybody else says there's nothing else left to do? There is something more to do, and that's what we're going to talk about. Intermittent pneumatic arterial compression, okay? Now, where did this come from? This came from Mayo Medical School, Ganda Vascular Center, their vascular ulcer and wound healing clinic, Mayo Clinic, Rochester, right? And it kind of looks like a blood pressure cuff, two of them, because that's what it is. Hooked up to a pump, because that's what it is, okay? How does the dang thing work? What happens, this inflates suprasystolic, and then as this one drops, this one inflates suprasystolic, and it cycles about 3 times a minute, okay? And you say, what's happening, all right? Resting ABI increases 18% in 5 to 6 months, but here's the big thing. Non-intermittent pneumatic compression wound, 2.1% area healing per week. The IPC wound, 19, almost 20% per week. And you say, how's that work? Well, whenever you see a slide like this in medicine, that means we really don't know how it works too good, okay? Because we're theorizing all those kind of good things, okay? Now, I'm kind of a dumb guy. I need something easy. Like, what's it do to blood flow? Well, guess what? Marked increased amount of blood flow in the popliteal artery, okay? Kind of important, all right? It's a way to measure it. Now, how do I think that works? In you and me, part of what makes blood go across our capillary bed is what I call the gradient, okay? Arterial pressure 120, venous pressure 0 to 5, okay? So if you've got really poor arterial pressure, and almost always, remember 80% of these people have venous disease, and if we pump their leg with an SCD, an IPD, whatever it is, and we get more venous blood out of the leg, we've increased the gradient, okay? So there's less pressure in the venous side, even though there's still the not so good pressure in our arterial side, so more blood gets across the capillary bed. That makes sense to me, okay? So, and IPCs and SCDs can help us, okay? Now, when this first came out, Medicare would pay for it. Now they don't, okay? I don't know how much it costs, but it still is very helpful. Summary, limb salvage possible in up to 80% of patients using a team approach. And in my mind, we are a team. We're a university setting. We need everybody here, okay? Everybody in this room, we need vascular surgery, we need cardiology, we need nephrology, we need internal medicine, we need family medicine. We need everybody, okay? All of us working together, then we can get into these kind of numbers, okay? It's just not us downstairs, all right? And when I see people, I say, you're not coming to see me, you're coming to see a whole team, okay? We are the team, and that's really important. It has to be customized for each patient, and that's really important. So, more information, Google the American Heart. It talks about those consensus documents. And again, that's pretty much what I live by. This is the professional organization I belong to, Society of Interventional Radiology. And so if you have questions and you want to call us up, feel free to do that. We take direct referrals. We take referrals from you guys. If you got a person with a wound, now if you go downstairs to the wound center, which is one of the really good wound centers, when the person first walks in the door, they got a checklist, okay? Artery disease, vein disease, ABIs, TBIs, venous disease. They ask all these questions up front. What's happening as I look out through Oklahoma? All the little bitty hospitals are starting wound centers. And they got people in there that put goo on wounds, okay? They clean them up, put dressings on them, apligraphs, all kind of stuff. And then sometimes they wonder how come the wounds aren't healing, because they never asked these questions to begin with, okay? So the first time you see a wound, you've got to ask those questions we talked about on the first slide, all right? The good news is, when they aren't healing, then they get to come see Duckett and Blackwell and the people downstairs. But the bad news is sometimes they don't make it and they wind up with an amputation, all right? So that's what we're trying to avoid, all right? Remember, American Heart, that's where we're at. Thank you very much. Any questions? Yes, ma'am. like that. So you're a pathologist? Okay. Actually, remember I said with the directional atherectomy, the TurboHawk, are you with me? We'll capture that material, and if I don't know what it is, we send it, okay? Because sometimes I'm asking, okay, is this a mycotic problem? Is this standard atherosclerosis? What is it? Now, the other thing we do this for that the pathologist might be interested in, what if you have a ureter or a bile duct, and you're wondering if it's got cancer in it? I can put that thing in there and get some really good tissue, okay? It's an expensive way to do it, but classically, especially with cholangiocarcinomas, uroepithelial kind of cancers, if it's a vascular structure and we're not getting a diagnosis, this is a great way to harvest tissue, okay? So from a pathology standpoint, it can be very useful. And when you, say if somebody sends you 3 specimens and they're convinced it's cancer and you can never find it, maybe, hey, talk to us, okay? Maybe we can help you, okay? That's useful. Anybody else have any